we'll move on. So any declarations of interest? Okay, none. I don't see any. We don't have any exempt business today.
The only thing I would add, Chair, is to meet your quorum. Councillor Al-Samarai has given an apology, and Councillor Cook is the sub for that today, and that maintains your quorum.
That's fine. Thank you very much. So if we can go to the minute from the 23rd of September. In terms, this is page 11 of the pack. So in terms of accuracy, anything on page 11, page 12, 13, any matters arising from the minute? Does anybody have anything? Okay, so that's fine. So that's approved as a minute and no matters arising. So if we go to the business planner, right, I know has joined us there.
Yeah, thanks, Johnny. I am here, but I'm passing over to Alison today, and
Okay.
part of future proofing in case I get hit by a bus. Alison's going to take the lead today.
Okay, thanks, Alex. So, Alison, did you want to say anything on the business planner?
Yes, I can do that better if I unmute myself. Yeah, there's just a couple of things. We did say that when we had the report on the directions tracker last time, that we would have that on our plan for every 6 months. Now the next one would be due in March because we had that in September. But I think, Derek, there isn't a meeting until April. Would that be right? That I don't think there is a meeting in March.
Caught me off guard, 2 seconds.
Sorry. And just while Derek is checking that, there is an item there on Operation Home First performance indicators. Says it'll come back on the 6th of January. That should actually be the 26th of January, just to confirm. So just a small typo there. Other than that, we did have a discussion on the Scottish Human Rights Commission. They have there was a seminar on the impact of COVID on human rights, and it was suggested that we perhaps bring a report to that on a future RAP committee. So I don't know if you want to add that to the planner as well.
That would be useful. Yes, thanks.
I think other than that, it's the planner is as it says. We have deferred or removed a couple of reports, but other than that, all the reports that are expected are here today.
Okay, that's fine. And I think where it reads 6 months, then you can take it as almost like 2 quarters. So whenever that meeting falls.
Whenever that falls, yeah. Okay.
That's fine.
That's fine.
And I confirm it's 27 April after the January meeting.
Okay, so it'll come to the April meeting then.
Yeah.
And again, through yourself, Chair, just for information, when you mention that every 6 months, I do try and make it like every second meeting if the 6 month isn't quite falling in lines. But Alison and I'll pick that up off table.
Okay, thank you, Derek. Yeah, and just at which number is it? 41. It's still reading APSC instead of RAP. If you can just change that in case somebody comes along and is wondering what that is. So
definitely, Chair, my apologies.
Fine, thanks. So any questions or clarification needed around the planner? No, don't see any indications, so that's fine. Thank you for that.
John, sorry. John, it's Luann here. Sorry, tried to put my hand up, but I've got a new
Okay.
computer and I can't find the button. It was just to highlight that we're currently having the inspection of justice services in the city, and I wondered if that report would come to the RAP when that's completed.
Is anybody able to comment on that?
So I think the criminal justice inspection is on the Clinical and Care Governance Committee's agenda. So I don't know if you want it to come here as well.
What did you have in mind, Luann? What angle on that?
So my thinking is about the processes and the sort of the governance system around our criminal justice services. So where clinical care governance may be looking at the sort of from the person side of things, I wondered if there was a role for RAP to be looking at, have we got the right processes in place and are we joined up properly governance around the services? So we might look at it from a different lens.
Mm-hmm. Well, certainly, can we ask that the officers have a look at that side of the inspection and as appropriate bring those aspects back to this committee as well? Is that okay, Alison?
I actually
that's
noticed
fine.
Alex has got his hand up, so he maybe has some information.
Yes. Did you want to come in on this, Alex?
No, other than to say yes, I agree that we will need to potentially bring that paper here, depending what's in it. But I suspect, from what I've heard, there would be some merit in bringing that paper to kind of triple handling that paper actually, which would be clinical care governance, RAP, and then the IJB, just so that everybody can get a good look at it.
Okay, we'll be careful to focus on the respective issues with it. Okay, thank you.
The bit I was going to raise was in relation to the finance report. So there's a finance report on the 26th of January. I think we're looking at an IJB date of the 27th of January, so that'll be a busy couple of days. But I think it's just in relation to the finance report. And you know that will be a late report to either of these meetings, given that we'll be trying to finalise the December information at that point.
Okay. So what are you saying there, that it would come to this meeting as well, or?
Yeah. Yeah, I think I would be tempted to bring it here, just to give a little bit more scrutiny of it, and then just indicate that, again, double report it, which isn't my preferred option. But I think given the position with the finances and the keen role the IJB as a whole's played in terms of monitoring the budget this year, I think maybe what we need to do is take it to RAP and take it there, just to kind of give it that level of governance oversight.
I think I'd welcome that, because the IJB has covered the finance issues, but if we could bring it here again, I can speak to you to make sure we don't end up with conversations duplicated, but okay. And it'd be the same report anyway, won't it? So it's not that you've got to do extra work.
Yeah, I mean, it'll be the same report. It probably brings the deadline forward a day, but I guess that, we'll be working hard to do as much work as we can in December, so we don't have as much work to do in January. But it's just, the December monitoring is going to be crucial for the IJB.
Yes, okay. And well, if members of the committee are happy with that proposal, I would also suggest, if you need an extra day to have a more up-to-date report, that it could go late to us, if are members happy with that suggestion. Yeah, I don't see anybody objecting to that. So we'll leave that in your hands then, Alex, to work out the timing for that. Okay. So I think that's us dealt with the business planner. If we can move on to item 5, which is the report on the asset management strategic statement. Alison, are you wanting to take us, introduce this for us? Thank you.
Yes, thank you, Chair. So this report is in front of you today as a result of the final outstanding recommendation from the internal audit report in 2017 on post-integration review, where they asked us to develop an asset management strategy. Now, to be fair, it's taken us a while to get to this situation. There's been a few changes in personnel and what have you over the years, but we have in front of you today our suggestion for what we're calling an asset management strategic statement. And that is basically the reason it's a strategic statement rather than a strategy, is that we are trying to keep our strategic plan as the only strategic document that we refer to. And when we refresh our strategic plan, we will build our asset management into as a feature of that. Also, in terms of assets, the IJB and the partnership do not actually own any assets. They're owned by our partner organisations. So it was felt that having a strategy on that was perhaps not the right thing to do. So what we have in front of you today is our strategic statement that basically lays out the assets that we use and the arrangements for managing these, mainly, as I say, through our partners, and also in terms of social care services. Obviously, we outsource, we commission from external organisations the vast majority of social care services. So they're delivered on premises that are either owned or leased in the main by the providers that we commission the service from. So the strategic statement is there in front of you. This will close off that final action. As I say, we have consulted with internal audit and their content that the document that is in front of you today will close off that action. So I'm happy to take any questions on it.
Okay, thank you for that introduction. So can I open that up for questions and comment on this? Okay, I'm not seeing any hands. Okay, Luan?
First, and this is probably just a daft lassie question, but so what difference does it make to have this document other than the audit point? Is it, you know, where does this go now? Would be my first question.
So in terms of what difference it makes, I guess it articulates for many people just the situation with our assets. I'm not entirely sure that was clear previously. So I guess it just closes off that that little gap, if you like. In terms of, so what about assets? Asset management is usually a fairly major part of an organisation, but it just clarifies for everybody, you know, just what the situation is in terms of the partnership and in terms of the IJB. So it will sit there as one of our governance documents, basically.
Thanks, Alison. That's really helpful, and I'm glad I asked just to clarify that. I suppose one of the bits that I wonder if we could make more of in the document is it's maybe around the principles that we would use, because I think the IGB, as I read this, is an influencer of other partners who own assets. So I'm wondering about a principle around our role in addressing inequity or inequalities, whatever the term you'd want to use, and by that I mean where we are around, you know, a development of a new asset, that we're looking at community benefit clauses that are built in, so that our communities where we've got issues around poverty have opportunities due to a new build happening in their area, and also community asset transfers, and just maybe making making a mention of that in the document as a part of what we can influence, because that will obviously then align to our strategy of prevention and maximising fair outcomes for everyone. Does that seem reasonable, Alison?
Yep, that's absolutely fine. I can add something in around that.
Thank you.
Thank you, Luann. And Councillor Cook?
Yeah, no, I was just going to say it makes complete sense to me. I like the fact that internal audit have signed it off. From a council point of view, I think it's quite helpful to have this statement to share with officers as well as elected member committees, just in case the council is thinking of doing something which would run contrary to what we're trying to do as an IGAB. So I think it's fine by me. That was it. Didn't have any questions.
Yeah, no, thank you. That's helpful. Thank you, Councillor Cook. Okay, I don't see any other anybody else signalling. You've already answered the question I had, which is what happens with the refresh of the strategic plan. I think building on Luann's comment, it is essential for us to have that within the strategic plan, because the whole notion of transformation will require assets to be either utilised differently or for there to be different in the future. And although technically we don't have the ownership, we do have the strategic position, and so it's incumbent on us to be clear about that. Alex, did you want to come in?
Yeah, John, it was just really on your point there, and I think it's I think you've hit the nail on the head about what facilities look like in future, particularly in living with COVID, or even after that. There is going to be how we design buildings, or how buildings are designed in future, to make sure that we can have the best infection control procedures that are possible. And I think based on the information that came out from the Scottish Government, we started to see last week in the report about care home deaths, they started to talk about size of care homes, and that's maybe something that will need to feed into future proposals about what care homes, what size care homes look like, and what sort of layout and so on that they have in that regard. So I think we're looking at a moving picture there, but I would certainly endorse what you said about looking at what the design of these facilities look like in future, and certainly something that as an IGB we're mindful of and thinking about.
Thank you. So all those contributions I think have been helpful in saying, yes, this is really a good place for us to be, and then it will be reinforced through the next iteration of the strategic plan. Okay. And I think on page 25 of the report, where you've got the action that's taking place and the, by when and who's taking it on, enables us as board and committee members to come back and see some of that detail and inquire about that if we need to. So, okay, thanks very much for the work on this. And if we go to the recommendation on page 17, we're asked to note the statement and to note the completion of that internal audit action. Okay, so we're all content with that. Thank you very much. If we can go on to item 6, and I'll bring Simon in. So this is the Alcohol and Drug Partnership Funding, page 27 of the pack. Simon, welcome, and would you like to introduce the report?
Sorry, John, could I just come in just before Simon does,
Certainly,
if that's okay? It's just to highlight that we had thought that we would be able to deal with this paper under officers' delegated powers. But we've been having a look at it over the last couple of days, and we now think that perhaps this paper will have to go back to IJB. The directions that we got in, or the directions that we gave from the 2019 paper, we feel doesn't perhaps cover what we are now asking, these changes that we're asking for. So although quite happy for this paper to be discussed at the RAP committee today, we will, and for you to input into the final decisions there, we will have to go back to IJB just to issue the revised directions as a result of any decisions. So just to make that clear before you start considering the paper.
Okay, so from what you're saying, if we take page 27, where the recommendation is for the committee to approve the proposals and agree that APD progresses developments, I'm assuming that the variation we've got here is that we can, as a committee, approve the proposals,
yes,
but that we then remit that back to the IJB to make the appropriate directions to enable the developments to progress.
Yes.
Yeah, okay. So Derek will craft something along those lines, and we'll go back to the recommendation before we complete consideration of the report today then. Okay, so thanks for that, Alison. Over to you, Simon.
Good morning. So this paper is hopefully quite straightforward in that the ADP has set out a direction that it wants to go in terms of investing some of its resources in a number of projects. The funding that's available is a mixture of underspend and slippage related to projects that, as we just heard, were approved by the IJB previously. So it sets out a number of projects that, from the direction of Alex, with the direction of Alex, given us to sort of develop projects that could be implemented quickly and easily by local providers, and that will have an impact that relates to the emergent needs of COVID and the various operations that are going forward to help mitigate some of the risk that our communities might be facing, and to help address some of the health and social care debt that might be accumulated in our population as a result of COVID and the challenges that people maybe face in relation to drugs and alcohol. So there are projects itemed at 3.16 with details in the appendix. These have been developed through the ADP and sort of collectively come to a total of £400,000. Most of them are non-recurring projects for fixed periods of time, and as with other developments and projects that the ADP is taking forward, as and when these projects are demonstrated as being effective or not, we would then be looking to redesign our existing services and structures to mainstream and take these projects forward. So I'm happy to take any questions, and if there's any of the detail that people would like clarified. And overall, the aim of the paper is to be able to reconcile the finances that the ADP has and ensure that there's an appropriate audit trail that's managed through this committee.
Okay, thank you, Simon. Thanks for your work on the report. Can I open it up for questions and comment then? Okay.
John?
Oh, wait, Councillor Cook.
Hi, thanks for that. Yeah, looking at the paper, it seems to be all pretty sensible, all moving in the right direction. Question in regards to paragraph 3.15. There's a comment around there around assumptions and uncertainties requiring clarification. I wonder if it's possible to expand on that.
Yeah, so these projects are being proposed on the assumption that the full amount of ADP funding will be available. So at the moment, some of our underspend is held with the Scottish Government. And whilst we've had an informal email confirming from a civil servant that this funding would be fully available going forward, we are still awaiting formal written confirmation from the Scottish Government. And that relates to funding that we didn't spend in 1920 financial year.
Thanks, that's helpful. And then I think in your remarks, you probably answered one of the questions I had, which was around the, these are kind of short fixed-term projects, but if it looks as though it's sensible and it works, the things that we continue to look to carry forward into the future. And I was looking in particular at the in the appendix, the one on Young People's Resilience Hub, which was for 3 workers for 9 months. Presumably at the end of 9 months, we'll have a look and say, this worked, this didn't work. And if it did work, we'd be looking to carry it forward longer term.
Yes, exactly.
Great, thanks. That was all I had.
Okay, thank you. Councillor Bell?
Thank you, Chair. I've got a couple of questions actually. So first one is at 3.14, which is on page 30 of the pack, and that's related to the GP Vision programme. So the pack says the report says it sought to invest £10,000 annually in licence fees to upgrade vision to enable recall and flagging of risk patients. This aspiration has been superseded by natural system improvements. I wonder if you could just elaborate a little.
Yeah, sorry. Hopefully it's not too... I tried to avoid using too much jargon, but I've kind of not succeeded in that. So Vision is the GP system that practices run on for all our sort of health records. There is another system called EMIS, so some practices use that. So the functionality that we wanted from that system was to be able to flag people for routine harm reduction work, so a bloodborne virus test, or to ensure that they had an naloxone kit. And to get that functionality, we were going to pilot a system called Vision Plus, and that functionality has now been mainstreamed into Vision, so we're no longer having to fund and pay for that additional function, if that makes sense. So what we were going to be piloting has now been overtaken by natural development within the system, if that.
Okay. Yeah. All right, thank you.
I can reword that if it's not clear. It's quite a technical.
I just wondered what the what the other system was, because I know that GP Vision GPs have been have got this near me system, so forth. I wondered if it was all related to that. So just one just one big license to cover everything, as it were.
Yeah, exactly.
Yeah. Thanks. And then my next question is on page 36, and that says between the 7th of April and the 12th of May, substance use was raised 91 times. So that's quite a lot. But that's 91 separate cases. Is that 2 people, cleared about 4 people?
Yeah, it could be a mixture. So this was information that was pulled by Director of Education and Chief Social Work Officer in developing the Young People Resilience Hubs. I also think that the name that they're using is no longer the Young People Resilience Hubs. I think that's sort of developed on a little bit as well. So it could be a mixture of a number of issues being raised. It was in the very early days of COVID, whilst the schools were on holiday and we were under sort of lockdown, that some of these problems were emerging.
Right.
But I can't get that clarified if you would like.
That would be quite useful, actually, please. And then finally, whilst you're scribbling, I'm sure you can hear me whilst you're scribbling. So on page 39, the report, the appendix mentions 75 specialist drug and alcohol staff with access to 4 laptops. which doesn't sound like a large number. I mean, all these people are working from home now. I don't suppose they want to use their own devices, so they need mobile devices. But then that also brings the question up: how on earth do they get access to broadband if they don't want to use their own devices? Do they have broadband available? Are you going to provide them with 4G dongles? I mean, how's that going to work?
Okay, so far in our work with sort of supporting staff, that hasn't come up as an issue. I think it is a good question. We have sought clarity that people are able to use Aberdeen City Connect to link into the various systems, which is a free citywide Wi-Fi service that's available to people. But I guess that's a question that actually would apply to the whole of health and social care, and where we're asking people to work from home. So I don't have an answer for that.
True. No, true. It's just that there we are. We're all we're all on our video devices, and and this broadband connectivity everyone's expected to have. I have, you clearly, people here have, but not everyone does. And it was just a thought. But 4 laptops amongst 75 specialists, that doesn't sound like a wonderful ratio. Thank you.
No. Yeah.
Okay, thank you for those questions. I had a couple of questions. One is welcome, and I think we got this at the IJB as well, the early intervention and prevention approach to this, which is in line with what we're seeking. But I want to reflect back on, there was the problem before of the delays in the projects because of recruitment, etc. And then when we've got the likes of 9-month posts, are we going to end up in the same place again, or what is it that you've been able to plan through these projects to give us some assurance that this time around the recruitment will work?
Well, I guess, the problems that we had previously were, I suppose, the funding coming in partway through the year, I guess getting the business cases developed and agreed by partners, and at the same time we were doing the improvement charters for community planning. So there was a delay getting through those processes. And recruitment has played a part in terms of some of the slippage, but it's probably not the main factor. And going forward, I suppose we then hit COVID, which delayed some of the plans further. And going from here, hopefully, we've engaged with a number of providers who have existing contracts, etc., that are in line with what we want to try and do. I've been working with the contracts team to ensure that anything that we do want to do, we can move forward quite quickly with contract amendments, etc. So we wouldn't necessarily be looking to go out to tender on any of these. We'd be looking to append to existing contracts and use the flexibility and the dynamics of the third sector to help us get these things moving forward.
Okay, and obviously, we can't give the go-ahead today from what Alison was saying, so this is wait to the IJB and then you get moving with it, or are you able to put things in motion before then?
I guess that's a question for you guys, and Alison and Alex and Jess, who's been helping us with the sort of logistics of the legal side.
Yeah, well, I suppose from our point of view as a committee, we can't go further than remitting this to the IJB, but I suppose whatever is feasible within the legalities of this to make progress, or just preparing for stuff, would be useful, assuming that this is going to go through the IJB, I think. Yeah. Alex, did you want to come in?
Yeah, I think just to kind of highlight what Alison said at the outset, initially when we had a look at this reunification, I felt the figures fell within officers' delegation. So there was an off. We potentially could have dealt with this without actually seeking approval. But there are a couple of these, or three actually, or 3 or 4 of the actions that have come forward here where the level of delegation is out with. So we'll have another look at that and just see what needs to come. But the IGB will only need to agree the ones that can't be agreed by officers.
Okay, so that's maybe where would it be helpful for us then to, in our recommendation or in what we approve, is to approve the ones, or just remit to the IJB those that require a new direction.
Yeah, that's correct. But Jess is here. I'll let her come in. But hopefully Jess will say the same as what I'm saying.
Okay, Jess, what's your take?
Hello. Yes, it'll just be a case of just as you've said. So the instruction from the IJB on the 8th of September was for this committee to approve the redistribution of funding. So what we will really be looking at is which projects don't fall within the redistribution that require further direction approval, and match that back to the direction in 2019, just to make sure that the governance follows through from the direction given with the funding to what it is that's before you. So if you, in terms of your recommendation, if you simply, let me just go back to it, you've been asked to do.
Yeah, page 27. There.
Yes, thank you very much. To approve the proposals. So I think what you could do is just simply, if you're minded to approve the proposals and agree that they progress, and perhaps include a second one in there that says that you acknowledge that any that fall out with may need to go back to the IGB for approval and direction, or words to that extent. Derek and I can sort out the exact wording, but if that's what the committee's minded to agree, we can sort that out.
Okay, thanks. We'll bear that in mind, and I'll come back to that. I think Luann's got a question first. Thank you, Jess. Luann?
Thanks, John. Yeah, just 2 questions. Just going back to John Cook's point about the recurring funding, I just want to get more of a sense of, is there money that's identified? I'm wanting to get a sense of how realistic it is to be able to find money in the system that can be used for these, and wanting to just make sure we're not at risk of kind of robbing Peter to pay Paul in a year's time if these are proven to be really successful. So that's my first question. There may be projects in mind that are time limited, and that would be good to hear.
Well, we've got a mixture. I mean, I guess people who have been to the ADP and to the IGB and people who saw our annual report will see that a vast amount of our funding currently is within secondary care services. So treating the impact of drug and alcohol problems in the community, and probably less sort of focused on prevention and early intervention. So my ambition is that we get the ADP on a more sort of balanced scorecard in terms of an equal spread, or a more sort of diverse spread of investment in prevention, early intervention work, and that we look at redesigning some of our specialist services a little bit to accommodate that. So that's one aspect. Our current contract with our providers, specialist providers, is due for review and potential recommissioning this time next year. So in terms of redesigning that specification and building in some of these early intervention prevention projects would be another avenue. And there's also been funding made available through the Drug Death Task Force, which is the national body taking forward the sort of public health emergency aspect of drug-related deaths. So there is in the pipeline sort of additional funding and additional sources of funding that we know about. So between those sort of 3 strands, that's where I would be looking to try and sustain existing pieces of work. Thanks, Simon. That's really helpful, and actually really
sits well with the home first approach of that pathway and taking more resource into the community. So that's really good. My second question is a broader one, and I'm thinking of COVID impact here, and we know that there's significant impact on mental health in our communities, and I think many of us will know that therefore that's likely to have a link with more alcohol use and more problem drinking. And I'm wondering if there's capacity in what's already around in the city to deal with more referrals coming through, or to reach out and connect with people maybe at an earlier stage. I suppose I'm thinking of more unemployment. You know, there's likely to be people struggling with alcohol that maybe previously weren't. So just to get a sense of, is that factored for within the current arrangements in the city?
I think so. Some of the immediate emergent needs that we see, so people coming out of prison, for example, where the community that they're coming back into is quite different to maybe when they went into prison, is one aspect. The sort of impact on emergency department in terms of alcohol presentations and overdose presentations in relation to drugs. So these are things that we can develop strategies in the community to try and reduce and develop a better system by working in partnership to help reduce the impact on our emergency services. I think longer term, I think we are starting to try and discuss and plan for any particular health debt. So I think the bloodborne virus one is a good example where we know that there has been a reduction in the number of people accessing clean injecting equipment, and we kind of have some evidence to suggest that that doesn't mean that people have stopped injecting. The concern would be that they're using dirty needles and potentially sharing injecting equipment. And we know in Glasgow, for example, there's a big outbreak of HIV and within Lanarkshire. So starting to think through how we might get early warning signs of any potential risks in the community, and sort of gearing up what we need to do to try and regain some of the ground that we had. And so that, for example, that the project that's about near testing and early detection of bloodborne viruses is one of those steps. Again, sort of the aspiration would be, and Alex's point about having officer delegation to be able to progress some of these projects, is to be able to work quite agile on quite an agile basis to respond to emergent needs, whilst at the same time sort of meeting the needs of governance and audit requirements.
Okay, thank you.
Okay, thanks everybody. I think that's all the questions. I don't see any other indications. So if we can just confirm then, is the committee content with the proposals for the recommendation just to be adjusted? So Derek and Jessica can work out the exact details, but it will be along the lines of the existing recommendation to approve the proposals and agree that the ADP progresses developments which do not require a further direction, and then possibly a second decision that to note those proposals which require referring to the IJB for a new direction. And I think the IJB meeting's 1st of December or around about then, so at least it gives you this month to press on with those that don't need the direction. Okay.
Thank you, Chair. Through yourself, I wouldn't want to steal Jess's thunder. Jess, do you want to suggest the amended recommendation just so committee can hear it?
Yes, sure. It's working in progress just now, but it's going to be something along the lines of that the committee notes that some projects highlighted within the report require to be remitted to the IJB for consideration, approval, and a subsequent direction made to the relevant constituent authorities where appropriate.
Great, write that down quickly. Okay, everybody happy with that? Yeah. Okay, thank you very much for that, and thank you, Simon.
Thank you for your support.
Thank you.
If we can go on to the next report, which is Operation Home First and the priority projects for the city. Alison, over to you.
Thank you, Chair.
Oh, can I just say, sorry, Alison, that what we will do just for the committee is that we will consider questions in order of the various projects, so that we're not jumping backwards and forwards across them. As when we get to that stage, we'll go through each of the projects in turn for any questions. Thanks.
Thank you, Chair. So you have in front of you a report in relation to the priority projects for Aberdeen City Operation Home First. You heard in September around Operation Home First in general across Grampian, and some of the preparations that are being made to evaluate and report on progress on that. But this report is specifically on the Aberdeen City aspects of Operation Home First, which all our efforts are aligned to at the moment. So the report just generally reminds you of what these priority projects are, and gives you some highlights of things of note. But as the Chair says, we have added to the appendix the situation reports and the flash reports by project, and happy to work through those and take any questions that you may have on those in particular. I do have some members of the team with me today to answer any questions that I might not be able to answer. So happy to take any questions.
Okay, do you want to first of all just introduce the members of the team who are here?
Of course. So we have Susie Downey, who is here and can discuss care at home and stepped care. We have Kay Dunn, who is leading on the mental health and learning disabilities. We have Sarah Gibbon, who's leading on 2C and CTAC. And we have Heather, who is leading on Frailty Pathway and digital.
Okay, welcome to you all. So thank you for coming along and supporting the committee today. Can I take any general comments or questions about the report as a whole and the themes, and before we go on to each project? Are there any? Okay, I don't see any signalling for that. Shall we therefore go on to the projects? So I presume if we go to the page 66, that starts there, and we have the Frailty Pathway. Do you want to take us, well, first of all, are there questions on this Frailty Pathway? Okay, let me get off lightly, Heather. I think, oh no, Luann.
No, sorry, just slow. But I suppose overall, just to say it's really helpful to see these reports and the flash reports that provide a little bit more detail. So I really found it a really useful and helpful read. So thank you all for that. My question is really about the timelines, and we're seeing that there's a change in the timelines since the last time we heard about Frailty Pathway. So I just wanted to understand, are we still confident that we're going to be ready for the, as demand increases over winter? And what contingency measures are there in place, or are there contingency measures in place, if we have additional challenges with COVID or other unforeseen challenges that affect the pathway?
Yeah, I'll take that one. So what I probably should have said in relation to the Frailty Pathway is that we've just undertaken a fairly major refresh on looking at that. And it's the overall timeline. So for for delivery of the full completion of the project that has changed. There has been a lot of work undertaken. We have our Ward 102 in ARI up and running, and we have other elements of the pathway in place. We've still got a fair bit of work to do, but we have a very clear plan as to how we're going to achieve that. So we are as prepared as for winter at the minute, and the new timelines that we have agreed just last week, we're confident that we will have as much of our preparations in place as we can have in time for when we are anticipating demand to increase. Everybody is working very hard cross system, not just within Aberdeen City. We're obviously relying on colleagues in Aberdeenshire and also our medical colleagues to help us put all the pieces of that jigsaw together. So we haven't quite completed the picture yet, but we're well on.
Thanks, Alison.
Thank you. Can I just ask a broad question here that kind of relates to some of the others as well, which is there's a frailty pathway for Aberdeen, and there's also for the other Aberdeenshire and for Moray. And are we taking a lead on all three, or does each take its own lead?
So we're taking overall lead for delivery of the frailty pathway for Operation Home First, but we do have, as I say, we have colleagues in medical, we have colleagues, and in terms of Moray, their input to that is in terms of confirming medical cover is available. So that so Murray's input is covered via the medical work stream, and our colleagues in Aberdeenshire are leading on the work that they need to do. So there's an overarching programme that draws all of these strands together. But I see Sandra wants to come in, so she'll want to add to that.
Sorry, Alison. Yeah, just to clarify, the frail elderly pathway is the reason for City leading is we host this, and it's still part of our scheme of our delegated services that we host the frail elderly pathway. So until everything is well established, although there is all the additional work streams that are undergoing, we still hold ultimate accountability and responsibility for these hosted services in the meantime. So until that's formally reviewed, so we're working with our partners, as Alison clearly suggests, but I'm sure you are aware, but it was just a wee reminder about the hosted proportion.
Okay, yes, and I suppose what I'm just interested in is, so anything that touches Aberdeen, we see in these priority projects, even though some of it's led by maybe some other IJB. So is that the case? So there's nothing that's happening in Aberdeen which isn't reflected in this set of papers that we've got, or not? And it's just
that's correct. This paper covers the activity in terms of Operation Home First that we are responsible for.
Yeah, for the population that we have. Yeah.
Yes.
Okay, that's fine. I thought that was the case, but I'll probably ask that again another point just to confirm that. But thank you very much. So any other questions on the frailty pathway before we move on? Luann, you have your hand up still? Is that, yeah, okay. So if we can move on to the mental health one. And you say, I think Kay's here for this. Okay, Luann, do you have a question?
Yeah. Just get my notes here. So it was just to understand that there's mention of the clinical challenge, and that might affect timelines for the mental health pathway. Just wanted to understand a little bit about what that is and how that's being addressed.
Yeah, I mean, we've had overall consensus about the recommendations going forward, but clinicians remain nervous about the bed base moving forward through COVID. But we've scrutinised all the data, and we've looked at all the patterns and trends through COVID, and we're quite confident that shift still can happen, and it's it's very much about our resilience to COVID, being able to commission those EMI beds in the community and keep people in the community and not coming into hospital. So the overall bed base, we're not reducing, we're retaining the overall bed base. I think there was some concern that we needed to increase that, but at the moment with staffing, that would not be a sensible option for us. So we're continuing to work with consultants. They have now signed off the report, and we've spoken to the Mental Welfare Commission about the recommendations, and they've come back with a positive feedback that what we're doing really is in line with the type of shifting the balance of care and transformation required, and it is taking account of the need for resilience to be forward as well. But it'll continue to be difficult because these are difficult big shifts that we're trying to make.
Thanks, Kay, that's really helpful. Thank you.
Okay, Councillor Cook.
So yeah, I'm actually going to ask an almost identical question to Luann's. So the clinicians now have withdrawn their formal concerns. Is that the case?
Yeah, they've signed off the report. I think they continue to express a view about concern, and we'll continue to monitor it, and we're monitoring the data very carefully. But they have signed off that report now, and the Mental Welfare Commission support the recommendation. So we'll move forward, but we are just being mindful that this type of change is difficult. So we may find it difficult as we just go into the detail moving forward. We just want the board to be aware that there might be some slowing down as we work some of that out.
So you, if concerns prove to be well-founded, you could put the brakes on, yeah?
If there's anything that comes out through the implementation process that it makes us reflect, then the reflections will be made and the relative boards will be updated on any amendment to the delivery plan.
Thanks, that's helpful. Great, thank you.
Thank you for that. I've just got one quick question. It's around the use of Near Me. I think we were hearing a few months ago how this was enabling services to continue, and so that was very positive. I'm just wondering, with a few months under your belt, just in terms of the quality of transactions and therefore what the future looks like in terms of using this as an ongoing practice.
Yeah, I mean, the use of Near Me has varied in different areas. We've seen an uptake in the use of Near Me as time's progressing. People that were maybe a bit more hesitant to use it in the first instance have had to come on board and start using and testing that method. One of the things that we're currently working on is developing Near Me guidance specifically for mental health, looking at the emergent evidence around efficacy for clinicians about how it is a useful tool. And across the home first operation model, we've done the red, amber, green status for case progression. So that guidance will reflect when it is useful to use Near Me, but when you need to assess someone in person, and we've got that pathway around the Kildrummie Hub. So we're developing that as we go along, linking into some of the national psychology research coming out, just to give people more and more confidence as time goes on that this is a valid tool that has got efficacy built around it in terms of the growing evidence for it.
Okay, thank you. Yeah, and I suppose a wider question, it's almost the other side of the coin. Councillor Bell was sort of talking about staff having access to broadband and the like, and the same would be sections of the community who may not have the same access, and we'll have to be mindful of that across a whole lot of patient groups. Okay, Luann, you wanted to come back in? No.
No.
Okay. Well, thank you, Kay. I don't see any others signalling on that, so if we can move on to the next one here, which is immunisations, I think. Okay, do we have any questions on this? Councillor Bell.
Thank you, Chair. Yes, I'm not on my pet hobby horse, but I had and I still have some reservations about the immunisation programme. So can I please ask, I've looked in the report, so can I please ask where we are now? And I've read various numbers in the P&J. It's been a little, the report has been interesting because it's actually talked about the entire Grampian region, then it's kind of interspersed with the city. So where are we with the city, please, in terms of immunisations that we've actually achieved now from this 110,000 modelled in number of people that can be through that?
So from the Grampian report that we receive every day, our figures this morning, just to remind you, our share of over 65s and the at-risk groups total 68,161. So as of this morning, in total, we vaccinated 24,015. Which is 35% of our total. If you split that down in terms of over 65s, the total is 22,515, which is 58% of the total of over 65s. And we have vaccinated 1,500 in terms of the at-risk group, which is 5%. Which reflects our approach. We are concentrating on over 65s first.
Okay, so you're getting close to this sort of magic ratio, this is 65%, really, aren't you? For the over 65s. So that's quite reassuring, I think. So do you think, though, that not allowing GP practices to do opportunistic vaccinations was a good decision?
So I don't think it's my place to comment on that decision.
Okay, well let me rephrase the question. Do you think that would actually that could actually add a significant enhancement to the number of over 65s that have been vaccinated? I know we're at 55% or whatever, but of course it depends where that 55% live. But just a fairly broad brush question, because of course those nurses were intended to move to these vaccination centres that we have. I don't know whether they did or not. There was a real problem with actually getting appointment letters out. Why we used appointment letters as opposed to saying A to C, rock up on Monday, Tuesday, Wednesday, and we've got a database that they could use is beyond me. But yeah, that's just a personal comment to my question, really.
Yeah, so my opinion is that our issue with our problems in terms of the vaccination clinics were grounded in the appointment letters. In terms of staff, we've been able to staff the clinics, and our main issues with the earlier clinics were the appointment letters not being received on time. So that for me is the crux of the issues that we've had, and we've learned a lot of lessons from that, and we're certainly feeding that into the planning that we're doing for COVID vaccinations. So hindsight, it is a wonderful thing, but we will certainly make sure that we learn lessons from what happened earlier on in the process.
Okay, so one final question then, because I've been arguing about it. Sorry, I've been asking questions. It hasn't been hindsight. There's been foresight. But one question really is, sending out letters is a huge overhead, isn't it? It's a huge cost, it's a huge overhead. So why could we not have had, as I understand it, all these records were provided from GP practices of where the different cohorts, what the ages were and where they were and where they lived, so forth. But could we not have had somebody knock up, and I say knock up because this is all, I don't think it's being thought through particularly well, just knock up a Microsoft Access database with this data. You import the data, it's not rocket science, you import the data from Access database, someone rocks up to the vaccination centre, they don't necessarily need a letter, they just say, oh, my name is Philip Bell. And they start to type in Philip Bell, and oh, Philip Bell pops up, oh yes, you're in the right cohort, in you go, Bell. Job done, and that's a record. Why could you not have done that?
So I'm afraid I can't answer why we didn't do that. I wasn't part of that decision-making process. But what I can say is that, yes, we have learned lessons from what has happened, and we will feed that into our planning for the future.
Excellent. Thank you.
Okay. I think, thank you for that, Alison. I think well handled. I think these are very important questions which we've got to look at, obviously, that in terms of going forward with COVID immunisation programme, which might even be even more extensive in the future. And I think there's key issues there about what will be a robust system. So those lessons that are learned and how those are feeding into a future approach. I think the other aspect of this is what the IJB handles and what NHS Grampian handles, and I'm still kind of working out who's holding what in that. I think that needs to come out as well in terms of the future accountabilities here for this committee and board and for NHS Grampian as well. So there's a number of aspects which presumably we're going to hear about sooner rather than later in terms of gearing up for the future. I see in I think it was, I read in the reports here that, was it by November you were looking at having an initial plan, or there is a view about an initial plan for COVID immunisation going forward. So when would we be hearing about that at the IJB or this committee?
I would imagine you would be hearing about that very soon at the December IJB, I would suggest. We started a review of the flu vaccination process last week. That's being led by an expert on civil contingencies who's employed by NHS Grampian. So we all had to feed into that. There was an initial meeting of that group last week, and there was also an initial meeting yesterday of the COVID vaccination planning group. So again, we've got some modelling and we've got some work to do on planning for that, and we have to have our first phase of that plan back at the beginning of next week. And as I say, we would hope to be bringing an update on both how the flu vaccination programme is going and also the planning for a COVID vaccination to the IJB on that. That will be part of the Chief Officer's report at IJB on the 1st of December.
Thank you. Councillor Bell, did you want to come back?
Other than I reserve judgment.
No.
Thank you, Chair.
Yeah, okay. I've got Councillor Cook and then Luann.
Hi, thanks. Alison, by the way, I was really reassured by some of the feedback you were giving at the IJB last week in terms of lessons learned, and because hindsight's a wonderful thing. Can I just check on particularly on this issue of, will we send people to a centre that's near where they live as opposed to near where their GP practice is? I'm sorry to raise that again. I'm getting lots in my mailbag about that. So in terms of applying some of the lessons learned, will we just do that for the COVID vaccinations when that's available? Or will we be able to tweak things for the later stages of the flu vaccination? And I'm thinking that you've already got enough on your plate as it is, and so that might be a fairly hefty job. But if you could just clarify that.
Yeah, in terms of application of lessons learned from the flu vaccination programme, we're planning to apply these to the COVID vaccination. We do really feel we're getting on top of the flu vaccination issues, and therefore we're going to crack on with that programme as best we can. There will be some tweaks that we'll be able to do, but we're not planning on making any major changes. And in terms of the COVID vaccination, we're already discussing that will be done by home address as opposed to GP practice. Slightly different in terms of the COVID vaccination. Obviously, we will be eventually looking at whole population vaccination as opposed to a particular cohort. But obviously that will be phased I understand it will be phased in by age. So starting with the over 80s first and those in care homes, etc. So we will apply as much as we can as and when we can.
Thanks for the clarification, and I don't underestimate the magnitude of the task. So I think we should cut you some slack.
Thank you.
Thank you for that, Luann.
Thanks. I suppose just to note, I absolutely agree. There's lessons to be learned, and I'm really pleased to hear. We'll hear a bit about how that's been applied around COVID in December. So that's good to hear. And also, I'm encouraged that given this programme of vaccination goes on into December, that the figures you're reporting are really positive. So I just want to thank the staff. I can't imagine the workload and the logistics that's gone on, and clearly the challenges we've had, but to thank the staff that have been involved. And really, I appreciate very much the updates that the IJB have had, because they've been very frequent and we've been very aware of the challenges. So really appreciative of all the work that's gone to date. My question is about childhood vaccinations, and just wanting, I'm not wanting to put you on the spot and ask for numbers today, but I just would want to know either when we'll get a report on that, because I know that there were challenges around some of our childhood vaccinations, because obviously that's also a very important area, and we mustn't lose sight of that whilst we focus on flu, and also which is important. So I don't know if you're able to say anything today, Alison, or just let us know when that'll be coming for a report.
Yeah, so unfortunately I can't give you the figures today. That's not part of the Grampian report that we get on a daily basis. But I can certainly confirm that I'll bring those figures to as part of the update to the IJB on the 1st of December.
Okay, thank you.
Okay, Councillor Bell, I think your hand's still up, but I assume that's from earlier.
Sorry, Chair, that was
okay.
That was me being very thoughtful and not taking.
That's fine. No problem. Thank you very much. So if we can move on, some of these probably won't need too much scrutiny here. We've done quite a lot on digital recently, so that's the next one that's up here. Are there any questions around this one? Councillor Bell?
Oh, thank you, Chair. It won't surprise you to learn that I've got a question. So this really is near me. I'm just really wondering how well this is working. The reason I say that is just going to recount one tale I was told for an elderly gentleman who lives quite close to me. You know him well. So he has quite bad prostate cancer. He's also on warfarin. I don't know if I pronounced warfarin correctly, but you know, the thin blood. He has significant bleeds. Okay, and significant bleeds. Probably 8 weeks ago, he fell in his garden. He likes to potter in his garden. He fell in his garden, and he gashed his leg, one of his right leg. He gashed it badly. He was quite concerned. It really, I think, he got dressed. You know, the nurse turned up, dressed it for him, whatever. It wasn't healing. So after about 5 weeks, he contacted the local GP practice. And he's got a tablet device, you know, and they look at it and they say, oh, give it a month. Give it a month. He said, but I've already given it 5 weeks. They refused to have him go and visit the GP practice. They wouldn't let him. Now I am wondering whether this near me is being used as a bit of an excuse for not seeing patients. Now that could be, you know, that's probably not correct, but it does concern me.
Do you want me to take that one?
Can I just come in there? I think Sandra's going to come in as well, but Councillor Bell, I think in relation to that query, it would be worthwhile referring that to our clinical lead, So I think what I would recommend in relation to the instance that you've got there is that we discuss it, or we take it out of the meeting and have a discussion at the clinical lead. I'm just a bit mindful that some of the information in there was of a personal nature, and whilst you never mentioned the person, it's just in case it's identifiable. So I think there's a process that's there for that, and I think it would be rather we had a look at that rather than discussing that particular instance.
Right, thank you. But it was just a general principle, though, really, and thank you for that. So appreciate that. But in terms of near me, though, how successful would you say it is being? It's great for doctors because they can do things remotely. But how successful is it?
Okay, so if Heather could come in then and just explain how successful that has been, I think that would be helpful.
Hi there. Yes, I guess Near Me is obviously one of the tools that we've got for interfacing with patients. It's been one that's been very useful over the months with the pandemic starting. Within Grampian, we've worked very closely with some of our colleagues from Aberdeenshire and also in secondary care who were part of some initial testing prior to the massive rollout of Near Me across the country. We were very fortunate to gain in that experience and learn from them. So that gave us a good starter for 10. Another thing that we've done that's probably helped with the success in Grampian is we've not went off alone and just done an Aberdeen City own thing. We've worked together with our colleagues. We were one of the first health and social care partnerships to introduce training for GP surgeries way back in March, and we quickly got kit successfully rolled out. Across Scotland, in Grampian's actually one of the higher users compared to populations. We've been consistently at top of the tree. It's not just GP services that have been utilising Near Me. It's been very, very helpful for the likes of our health visitors to utilise it with their iPads to see their babies and do their children's reviews. We've recently seen an uptake of our link practitioners. Our link practitioner programme is one that's commissioned by the partnership. They found it very, very helpful to see some of their clients who have actually had a really downward spiral with their own mental health. They've also been using it to support new patients who've become into the burden of a financial detriment with possibly losing their jobs, etc., with filling in forms and PIP assessments, etc., etc. Our community nursing team will visit patients when they need to see it, but it's been useful for the likes of some long-term conditions that are having some carer involvement from a family member to give some reassurance. So that's where we're at with that. Near Me is a national programme. They are actually going to be rolling it out to some other public services, so you might have heard that. It's going to be used within the police and custody centres, and also we find that it could be probably quite useful for our social work teams as well. We're doing a lot of learning on the collection of data, and actually within Grampian we've went off the beaten track nationally, so we still support the national evaluation process, but we're really keen that we get some more evaluation around patient-centred feedback and also staff feedback. So now we have a form after consultation, and it's broken down for all areas, for secondary care, for Aberdeen City Health and Social Care Partnership, Shire and Moray, and likewise. These reports are going to be coming out monthly. We had our first report for September that's been circulated, and we're hoping to get our October report out next week. So that's certainly something that can be shared if you would find that useful. We're also developing our own database system for pulling out data. The reason being is the national system doesn't afford us to really break down per partnership. It only breaks down per Grampian area, and that's something that all the health and social care partnerships are really keen to see. They're more broken down figures. So that's something that we're working with our health intelligence team with as well. So that's an update for you there.
Thank you. So there's obviously quite a lot going on. But did I pick you up correctly, saying that new mothers I'm not being visited. Did you say that?
Excuse me?
Did I pick you up correctly when you said that new mothers are not being visited by health visitors? They're just showing them what their baby looks like on a TV screen?
No, it's a blended version. The first visits will be done by the midwife and then the health visitor. Subsequent visits can be done via the Near Me call, and they can also have a video call instead of a telephone call if they require any other guidance or information. That's why it's been superbly useful for the health visitors in Aberdeen City. Blended along with the health visitors, we've digitalised them recently, so that we're very fortunate that all our health visitors in Aberdeen City actually had an iPad device. They were able to access that, so that's been useful.
So sorry, Chair, to belabor this a bit. So a new mother then, she could be very anxious. If that health visitor can't turn up for whatever reason, then she remains anxious, doesn't she? So the health visitor makes an appointment. Say the mother is out with a baby, she's taking the baby for a walk. So that means then that she wouldn't necessarily see a health visitor. It would be by video only. I mean, how do you say, oh no, I don't want to do this near me, I want someone to come and see my baby?
That's obviously still an option for the parents. This is a blended option for them to get extra support to enhance care.
Sandra, would you like to come in?
Yeah, so just to confirm, I think that it's what we're saying, Councillor Bell, is that exactly what Heather's saying is it's a blended approach, that each individual circumstance in each family, so it's not one solution is not fit for every single family, but there are different options. And I think there has been a lot of support and a lot of feedback that this has been a much more accessible programme for people to be able to find that relevant support and different levels of support. And just as if you've said, if somebody isn't in for that visit, but these visits are all planned. If you recall, the IJB invested in our IT infrastructure for our health visiting and allowed us to move to a more digitally enabled focus, and that certainly helped us move forward there as well. So I do understand that if there is anxious, that people, not everyone is content for the Near Me option, but absolutely it is about what's looking for what suits each individual.
Thank you. May I just ask one more question, please, Chair? I'm sorry. So
Okay.
do you get any feedback from mothers, for instance, or from patients? Do you ever do a survey just to see what their levels of satisfaction are?
Yes, we do, and I'm pleased to share that this is something that we've been working with across Grampian. So we do have patient surveys. We've currently got one that was done for the month of September, and we've got one that will be due for October that should be due right next week. This survey is an optional survey at the end of every video call, and it's broken down per different areas. So we've got for Aberdeen City, Shire, Murray, and also our secondary care services. And it's certainly something that can be shared along with the report if you think it would be useful.
Okay.
Thank you very much.
Alison's probably going to come in on this, and then I'd like to make a comment as well. Alison?
Thank you. Sorry. Yeah, I was just going to, as Heather mentioned, I was just going to refer to that Near Me satisfaction report. 93% of users rate the Near Me experience as very good or good. And 69% of respondents said that they felt that there were no disadvantages to using Near Me. But obviously there's many more statistics in that report, and as Heather says, we can share that with you.
Okay, and I think that would be really helpful. I think what the conversations pulled out is that there are a number of aspects, because even those that are saying this is great are those that are actually engaging with it. It's those that aren't engaged are sitting out there as well. So it would be very helpful for us to see that report, and then we can come back and see if there are any gaps in that in terms of the perspective. Because, Councillor Bell sort of touched on some there. There are clear positives with this, and then there are clear risks in terms of some people being left out. And I suppose that's what we're anxious about, that and there's also change as people get used to something new and being able to transition. So it's right for us, I think, to dig into that, and presumably the performance report that we're going to get in due course around Operation Home First, we'll be able to see how far the measures pick up on these. But certainly if we can get sight of that first one, then we can look at it and see if there's gaps from our perspective. Better that we say that now than after the event when you've collected the data. So thank you for that. Luann?
Thanks, John. Just following from what you're saying there, I was struck with, I think if I picked up correctly, what Kay said earlier about having this red, amber, green system for assessing when people are suitable for near me and when they're not. If I picked that up correctly, is that just in mental health services, or is that a sort of toolkit that's being used for staff to assess? Because I suppose that's the risk, that there's an unintended consequence that some people just may not engage because, you know, for whatever reason, disability, digital access, age, whatever. So it's just to get a sense of, is there guidance that's out there for staff to help assess when it might be not even appropriate to offer that, but actually just to say, do you know what, we're going to come and visit, or we're going to do a phone call, or whatever's more appropriate.
Yeah, there's been lots of guidance developed over the last 6 months, or improved guidance as well. These guidance, they have actually developed via service. So initially it was for general practitioners. We've then seen other guidance that have come out for specific practitioners, such as allied health professionals, the use of using Near Me in secondary care, using it for the purpose of virtual visiting. The guidance that's been developed for GPs has been done in partnership with general practitioners who've been very new to using it, some who have been part of initial tests last year, and also their governing bodies as well. So yeah, we've got a lot of guidance out over the summer as well. There's been lots of webinars that have been taking place for staff. We plan to do another one in Aberdeen soon. We just had some discussions last week around that, just around identifying and supporting some of our practices locally that maybe haven't engaged so much. There's also some guidance that have been coming out for those who speak different languages as well. We can also, before we weren't able to use interpreter services as well, so been working with our equality and diversity team in that as well. So I guess from what we first got in March when we launched, it's kind of been ongoing enhancements that we've had to progress and learn with. And as you know, in Scotland is best practice, and being shared now down south in England, Wales, and wider across the world as well. So that's good.
Thank you. That's really good, and I'm really encouraged, because what we don't want is a one size fits all, and that's absolutely not what you're describing there. So thank you.
Yes. Okay. Thanks for that, everybody. And Sarah's put a note into the chat as well, just on this. So I think it is key that we get a balanced picture of what is actually happening here, because there are so many potential positives that can come out of this. It's just capturing these other elements and seeing how they're accounted for. Okay, right, we've gone through 4 of these, we've got 10 of them, and I'm just conscious of our time. Are people okay, or do they need a break, or should we press on and complete this? Just press on at this point. Okay, thank you. So the next one we have is the, I think it's the empowerment groups, locality empowerment and engagement groups. So any questions on what we've got here as an update? Okay, so that's helpful to see the progress in this. Alison?
Sorry, Chair, just to say that there will be a report coming to the December IGB on the progress on working on localities, which will cover the locality empowerment groups at that point as well. So people might want to wait and see that report before any questions.
Yeah, that's helpful, except Luann's here. Luann?
I know. It's not a question, more just an ask for when that report's been developed. I'd be interested just to hear about how we're making sure that it's a diverse spread of people that are engaging with the legs, and also what we're doing to engage with groups of interest that might not be geographical groups. So I'm thinking of LGBT community, other groups that we need to hear from too. So that's just an ask. Thank you.
Okay, I'm sure that'll be noted there. Thanks. If we can go on to number 6, which is the community treatment and care services. I think Sarah's here for this as well. Yeah. Luann?
Sorry, I hadn't taken my hand down. I'm just interested to hear a bit about it. Thank you.
Right. Anybody with questions on this? Okay, well, thank you for that update. If we can go on to the 2C redesign, we've had quite a bit on this very recently. So is there anything anybody wants to comment or ask today? Okay, and then care at home. We've gone from one extreme to the other here. Whistle stop through this. Okay.
Sorry, Chair, could I just come in with care at home there, just to say that the care at home, new care at home contract started on Sunday. And I was actually senior manager on call over the weekend, so can report firsthand that everything seemed to go very smoothly. We had no hiccups at all. So, great work done by the team in terms of all that planning and preparation. Certainly seemed to come to fruition on Sunday.
Okay, thank you for that, Alison. I had one quick question, and that was just to understand the transfer of packages, just from the point of view of the individual person. Does that mean that some providers are moving out and that package is going to another provider, but does the individual person have a say in that, or is that just going to happen? Just to understand, I think in different areas of Scotland that's handled differently. I just want to know how we're dealing with it.
Yeah, so as far as possible, we're trying to ensure that certainly the individual continues to receive care from the same carer. Now, that carer may have transferred under 2P arrangements, employer, and may be wearing a different uniform, but in general, we are certainly trying to ensure that there's that continuity of care. Not all of our existing providers were successful or wanted to be part of the consortium that are now providing care. So if that provider didn't move into the consortium, then they will no longer be that provider will no longer be providing the care. But if, depending on the workload of the individual, if that individual was supporting Aberdeen City clients in terms of their main portion of their job, then the 2P principles apply, and that individual would transfer to a new employer, but would continue to deliver the care to the individual. So there may be some individuals across Aberdeen City who are experiencing slight changes, but we're again, a lot of hard work was done to try and make that change as seamless as possible.
Okay, thank you.
John, could I just come in there just to confirm as well that clients would have had the choice whether to go with an SDS package 1 or 2, and therefore they could maintain the potentially maintain the services with who was there, and a number of clients decided to take up that option.
Okay, so their personal choice was protected.
Yeah.
Thank you very much. Councillor Cook.
Thanks. This is this might be a daft laddie question, but it's excuse me. since we're at the audit committee, as I understand it, the new model is moving to an outcomes focused thing rather than a time spent thing, which is totally the right thing to do. But as it's the audit committee, I'm thinking about the auditors saying, does that make it harder to monitor or measure whether the provider is actually fulfilling their contract? And how will we kind of get that? As I say, it's I feel slightly guilty for asking the question, but because I think the new model is the right way to go. If you comment on that.
Yeah, this is something we've been wrestling with for a while. You're absolutely right. It's the right thing to do. But what we've traditionally done is measure time and task and measure the number of hours and all that sort of thing. And it is far easier, yes, to measure numbers than it is to measure outcomes. But we've from the care at home implementation group, we had a subgroup looking specifically at how it is that we can measure outcomes, and we have plans in place as for how we do that. There's a number of tools and mechanisms that we can use, but it does mean we're not going to get the sort of weekly figures that we used to get in terms of the number of hours that are delivered this week. We're having to ask or beg people's indulgence that they bear with us, because the outcomes can only be measured over a period of time, and obviously there's things like we will monitor closely things like complaints and adult support protection issue. There are other things that we can and other indicators that we can use that will indicate whether there's a problem in the short term, but the longer term in terms of is the new model making a difference to people's lives and how they understand that will take slightly longer to achieve that. And sorry, I've just realised I'm kind of hogging this a little bit, but I don't know whether Susie wants to add or come in and add anything to that.
You're doing a fab job, so I thought I'd just leave you to it. Yeah, the only thing I would add to that, Alison's absolutely right. There's two things around this: the question around measuring outcomes, but there's also the performance measurement of the actual contract. So things like staff attrition is another way to measure, how successful the contract has been. Training, is our staff getting trained appropriately? All those sort of performance measures, and they are all in place as part of the contract monitoring. The other thing that we're looking at is the qualitative side of things. So we're asking the providers, we're jointly working with the providers around how we measure outcomes. It isn't a done-to kind of conversation, it is co-produced. One of the suggestions that we are looking at is around case studies. So percentage of case studies from across all the providers from the consortium that would also be presented at the monthly monitoring meeting, as well as this tool which Alison is speaking about, which would be measurement of outcomes, but the ability to aggregate that up so that we can see the success of the outcomes. So hopefully that answers your question.
It does answer the question, and it's really reassuring, and well done, guys, and hope it works because we're doing the right thing. Thank you.
Thank you for those contributions.
Agreed.
Luann?
Thanks. Alison answered my question about the transition period and how if it had gone smoothly. So that was all I wanted to ask specifically on that. Thank you.
Okay, thank you. Thank you for that then, Susie and Alison. If we can go on to the next one, which is the stepped care approach. Have we got any questions on what we've been provided with here? Okay, and then Aberdeen Together, there's three aspects of this. Do we have any questions on this? Luann?
Hi, sorry, John, if we can go back to the stepped care, I'm just
Okay.
too slow with my Wi-Fi. It was just to get a sense of, so there's national redesign work around urgent care going on, and I just wondered how this links with the stepped care approach that's being developed in the city, or are they quite separate things?
who wants to go?
Yeah, I'll take that. So the urgent care is a national redesign. It is linked into the hospital at home. Well, sorry, the step care model, probably at the kind of higher end of the tier. And we are linked into it, I suppose, is the thing that we are kind of, I suppose, they're separate work streams, I suppose is what I'd say, but they link together. Is that would answer your question better? Sandra?
Yeah.
Oh, sorry.
It's just getting a sense that we're not kind of putting a lot of time and effort into designing something which actually nationally they're going to say, well, no, we're wanting it done this way across Scotland.
No, we couldn't do
where
that.
I was coming from.
Sandra, did you want to come in?
Yeah, just to add, the urgent care redesign is a lot about the navigation and the heading people in the right direction. I think our step care approach is something that's it's fundamental. I think you probably have seen similar things with our daycare approach, and it's that bit about making sure that we've got the right level of support at each level of where that is. So hospital at home, if you like, is the top, where the most dependent and acute needs are, but fundamentally that's the smallest part of our triangle. So it does fit in from both the pathways that the team are linked into from hospital at home are the discharge pathway. So definitely from acute moving out into home, but also more importantly is the prevention of admission pathway. And I think that's the bit that we're linking in. But the whole urgent care redesign, step care, that they're all inextricably linked and leading from each other. So an assurance there that yes, the team are definitely aware of all that.
Yeah, thank you.
That's really helpful. Okay, anything else on that? Okay, if we can go on to the locality, the Aberdeen proper heading here, Aberdeen together, and the three aspects of this. Luann, is that?
Oh.
No, okay. Alison?
Sorry, again, I was just going to say, particularly the first aspect there, the holistic locality planning, that will also feature in the report that's coming to IJB in December. So you'll get more information on that then.
Okay, that's good. That's anticipated my question, so I don't need to ask. Anybody else want to ask or comment on these? Okay, and then we have the flash report around Operation Home First evaluation. So we know that's a work in progress, and that will come back in due course. Okay, I think, and then the rest of the document is the just the original appendix. Yeah. Okay. Well, I think that's been really helpful from the committee's point of view. We've had the Operation Home First come on stream, and I feel that's us now having, I know it's taken some time, but gone through that thoroughly, and so as a committee fully understand where we are. So thank you very much for all the information and the work that's been ongoing with that. Luann, did you want to come in?
Thanks, John. It's just a more a reflection on, it's really helpful to see the flash reports and all the different bits of work, but I think as we've spoken before, what I think maybe the next step for me would be to see it all in how it all maps together. So what the links are between the different areas of work. And I'm probably quite a visual person, so I've got in my mind that the New Zealand approach, they had a very visual picture where they had Agnes at the centre, and they had their primary care and their community support and their volunteers and their hospital, and it was all mapped out on a page to show how everything joined up. So something like that would be helpful, maybe with a little bit of idea of numbers somewhere in that as well would help just see how it all joins for me. But I take that, you know, that's being thought about. But I guess that's just a reflection on where I'm at from today.
Yeah, and I think that that reinforces, I think, what I was trying to say, in a sense we can see the picture coming together, that being set out, seeing the different pathways, you know, across with acute as well, so the cross system, and then the dashboard which will come through. So I think it's starting to come together for us. I'm sure you've got a firmer grasp of that, but for us being able to be assured on and give proper scrutiny, I think that's been extremely valuable to have these reports and go through that in detail. So can we, going back to the noting the information, and then the reflections that we've provided can be taken on board as needed. Okay, so I think that's us finished with that report, and thank you very much to all the officers who attended for their particular parts. That was useful. Thank you. So that takes us to item 8 on the agenda, which is confirmation of assurance. So can I ask the committee members to confirm that they're assured by what they've received in the reports today?
Yep, fine.
Good, thank you very much. Okay, so we can minute that appropriately, Derek. And that takes us to the end of the meeting. The next meeting is, I think it was noted earlier, 26th of January. And would just like to also acknowledge to all the officers that, you know, through a difficult period, you've brought us right back up to date on everything, and hopefully from now we can get back into the normal cycle. But I know we've got a long winter ahead of us, so we'll see how that goes. But a sincere thank you to all of the officers for the work that you've done to enable us to do our job as well. Okay, thank you very much to everybody for your contributions today.
Thanks, everyone.
Thanks. Thank you. Bye. Bye.
Thank you.